So we're talking about understanding facial anatomy and its application in the correction of facial aging. In other words, we're not just learning anatomy for anatomy's sake. It's all oriented towards a particular goal. I just want to publicly honour Levant Effie. He has the capacity to visualise the anatomy, which is essential for an illustrator. Without him, we couldn't be here. For example, this illustration here, talking about the new understanding of anatomy, specifically ligaments and spaces. So putting this in a historical context, ligaments were first described, the term facial ligaments, really in 1989 by David Furness. So that's nearly 40 years ago. So anyone who trained before then didn't really know about facial ligaments. And then the facial spaces, which is something that I've been promoting and sort of helping to explain a lot of the anatomy and the aging, that was not until 2005. So this is new anatomy. So any surgeon who learnt facelifts before this time was very difficult because they had to figure out a lot by their own experience. And so that explains why, to me, why there's so much diversity of facelifting techniques, because it's like making a decision without all the facts, how to best do a facelift. But it's never too late to change, but there's no real reason for a surgeon to change his facelift technique if he's getting good results, predictably, because he's learnt from his experience. So the people who are learning facelifts, understanding this anatomy, is involved with a different type of thinking. And this is why we've got this, the two men arguing. The point is that anatomy can be taught based on principles, and you don't have to be a grey-haired surgeon to know anatomy anymore. The younger surgeons can know it because they understand the theory. So exactly what is anatomy? It's a branch of science obviously concerned with the body, and it's based on dissection. Dissection meaning separating the parts. That's the way you can learn anatomy, but you won't understand anatomy from doing that. So because understanding anatomy takes a lot more, we have to go back through the history of the evolution of the species, because that shows the basic structures before they became more complicated and may have moved to a different position for a different function. For example, the mouth is not used for articulation and speech in lower order species, and so the anatomy's changed for that reason. The functional use of the parts. Thank you for that. So it seems like we're digressing here for a moment, but it's to help understanding, and you don't have to remember the details of the evolution, but you need to understand. So when we look at the first vertebrates, which were about 380 million years ago, the face was the front of the head, the part that was propelling forward, where there's motion and direction, and it was defined by W.K. Gregory in his book in the 1920s, Our Face from Fish to Man, wonderful book. The face is a food detecting and food trapping apparatus at the front of the head. That's basically what it is, and yet here we are concentrating so much about faces, sometimes forgetting what it's all about. So if we go and look a bit more about food detecting, here there are three sensory placodes from the brain that are monitoring the external environment, looking for food. The olfactory, optic and auditory. So there's a central nervous system reaching out to the ectoderm, the exterior of the body, and then the food trapping apparatus is partly from the foregut and partly from the branchial arches, which we will go back to. But there's a different function in the human face. The human face has a social function, and that's something that's terribly important, and people wouldn't be having facelifts if it wasn't for the social functioning of the face. So we have to keep that in mind. In fact, the definition of the face is interesting because it's the front of the head excluding the ears, and you can see why on this lion, because in nearly all species, the ears are concealed by the hair that comes down from the head, and the only part of the face is the functioning, visible part of the face for communication, or food trapping and food detecting. So you can see there that the face really has a front and a side. And the front of the face, like the lion, is the most important part because that's where all the movement occurs and where the placodes are other than the ear. And you can see there, the eyes and the mouth, and in between them are the main expressive communicating parts of the face. And the most difficult to correct also, we would have to say. So it's the mobility of the face, which is essential for its functioning, which also is its downfall, because the mobility means that, as we'll go to in a moment, the structural attachment of the face is not as strong to allow mobility, and therefore over time there is a weakness. So if you have any mechanical apparatus that moves, it's going to deteriorate compared to a solid structural concrete wall, for example. Here you can see the junction between the two parts of the face. The lateral part is the area over the structures to do with mastication. There's essentially no muscles of facial expression over there, a little bit of platysma, but not significant. Completely different from the front of the face. And yet, when all of our surgery starts, we start in front of the ear. And a mini lift operates on the side of the face, not where aging is occurring, which is on the front of the face, but separated by the vertical line of ligaments. And just look at this animation to think about the amount of movement, the range and variety of movements that occur on the face. And how this can be accommodated by the structural design of the face and its components. So here are a few key points. So in this presentation today, I'm going to consider the anatomy specifically from the perspective of the eyelids and the lips. You know, they were the triangle of communication. Because the anatomy there, comparing and contrasting, we can appreciate some of the different aspects in a different way. So we know about the lips, of course. And this was I didn't realise at the time, you know, when you're exposed to a wonderful teacher and you enjoy it, you don't realise where it's going to lead you. So I owe a debt to my professor of anatomy, because we had to have tutorials comparing structures to make us think, which we were forced to do. So you can see the origin of the nasolabial fold is a very human thing, because if you look at your pet dog at home, there's no nasolabial fold, because the structure of the lips and cheeks, the way they integrate, are completely different, because the lips move with the jaws, not independent of the jaws. And there you see the nasolabial fold, the human feature. Now when you look at the surface appearance of someone, the surface anatomy tells you quite a bit about the appearance. And someone such as this, the face is like a mask. It looks like it's never moved. It just doesn't have any non-emotional expression of function. One day it will. Whereas a face like this tells a story about what's happened with the face over the years for all sorts of reasons. So you can see there are areas where the tissue has sagged down, and there's areas of hollowing above or thinning of the tissues, which is where some of that soft tissue has come from. So aging results from laxity due to movement. Pretty basic. So now let's look at the soft tissues of the face, which are in layers. As we all know, they're in concentric layers. And the fundamental difference is the deep fascia is quite distinct from the superficial fascia. So if you skin a rabbit, what you're doing is taking the outer layer, the superficial fascia, and it's still got the same shape and structure as a rabbit with skin as one without skin. So when we're talking about the face, most of our efforts are in the superficial fascia. Not all, but most. And what's amazing about the superficial fascia, what we're talking about here is the structures on the lateral face, you see, predominantly. And then when we go into the superficial fascia, the third layer in is the musculo-aponeurotic layer. And it's a remarkable thing about the human face is it has this whole layer of muscle under the skin, and the muscle is designed to move the skin, in contrast to usual skeletal muscle, which moves bones over joints. That's where movement comes from. And then between the superficial and deep fascia is what we call layer 4. And this is a very interesting layer, which is what we're going to be talking a lot about now, because through this layer there has to be attachments of the superficial fascia to the deep fascia. So this is in the form of ligaments, and yet there has to be mobility in certain areas, which we now call spaces. And you can't have a space and a ligament in the same position. It has to be one or the other. So in areas of larger movement, such as the lower face, due to the opening of the jaw, the space is large, and in areas of small movement, such as over the zygoma, there's much less space and more ligament, which has implications for surgery, because it means it's more difficult to dissect in layer 4. Then if we look at the outer 3 layers, they're fused as an anatomically composite flap. They belong together because they're all superficial to layer 4. And here the 4th layer, as we said, contains ligaments in some areas, and contains spaces in other areas, and all of the structures nurturing the superficial fascia, the nerves, motor nerve, sensory nerve, vessels, arteries, veins, and lymphatics, have to breach across that level to innervate the skin and the skin muscle. So here you see the facial nerve, which has always been the bugbear for surgeons performing facelifts, and even more so, theoretically, when you're doing sub-SMAS in level 4. But here's some very important information. If you look at this, we'll just reanimate that again. If you look here now, you'll see that the nerves are always outside the spaces. So here the nerve is deep to the floor. Then when it gets at the interval between spaces, it takes protection from the ligament and passes from deep to superficial to come to the underside of the muscle layer. So whenever you see a ligament, you're thinking nerves could be nearby, and when you're looking for nerves, you look for the ligament. Pretty simple. And so for surgeons doing facial reanimation surgery, cross-facial nerve grafts and the like, they've intuitively learnt this information. So now let's go back to the early vertebrate design, which has the branchial arches. And the branchial arches' functions vary to a degree with the evolution of the species, but they always stay true to their origin. So facial nerve innervates the facial muscles, and even though the facial muscles move all over the place, they still maintain their innervation. Now you'll notice that the shape of the human face, and we'll show this a bit later on, is the flattest of all species. And we were talking yesterday a lot about facial volumes, so if you have a flat face and it loses more volume, it's going to be even more significant flatter. So here we are. This is Australian freshwater crocodile. It's a basic format for a reptile. And when you look at the so-called thirds of the face, the upper third and lower third and middle third, the upper third is very small, because the same anatomy is there, but it's over a very small area because the cranium hasn't developed. Whereas all the structures of the middle third, when the snout goes back eventually, as you can see here, progressive resorption of the projection of the snout and of the dentition, all of the dentition is way back there under the orbit, or very close to the orbit, not way forward. So this has a major impact on the anatomy and the consequences of aging of the anatomy, which we'll get to. So we never think of the human as being extreme in its shape, but it is. Now the other thing, when you look at the facial skeleton, most of the skeleton, other than the upper third from the brain, in case protection, most of the skeleton is spaces. And this is very significant because there's more space than bone available, and the consequences of this is that there's a very small area of bone available for the attachment of ligaments and muscles. And when you look at the middle third here, you see that the bone is almost completely surrounded by space. So it's very vulnerable, and I give this analogy. This is the heads at Sydney Harbour, the entrance into the harbour from the ocean. And you can see that it's a similar thing. There's an isthmus there that's been exposed to the elements, the tides and the wind, and it changes shape over the years. And so does this part of the human face. So does this part of the rock of the face, the skeleton, change over the years. We'll just go back on this. So I'm introducing this early aging of the facial skeleton. But just look what happens to the maxilla. See the resorption of the maxillary tuberosity and loss of anterior projection. So much loss of volume of the face is coming from the skeleton. And here you can see in a side view the same thing. And look at what happens. Here's a person, a patient age 28, who I followed up over 10 years, and here she's 28 and 38, and look what happens to the projection of her cheek. That's dramatic. And she's not even 40 years of age yet, and there's this loss of projection of the skeleton. No wonder so many women are having fillers, particularly in Asia, because they already have a flatter face than a Caucasian face. Just look at that again. That's going back 10 years, and that's very profound. I'm hoping this will wake you up and get started thinking a little differently, maybe. So we know the muscles of facial expression come from the second branchial arch, and initially they appear in the fish underwater, so they can't be mobile. The skin is not mobile for underwater swimming, and it's limited to the neck. But as the species moved out of the water onto land and into the air, the musculature moved as well and completely surrounds the whole face and head. That's the layer. But then with higher functioning, areas become more differentiated. Just like we specialise in areas and we lose our specialty or knowledge in other areas, so the muscles of the face are very specialised for the part that they are working. And the areas in between that have undergone regression are fibroaponeurotic. So that goes back to what we were talking about before. The skin has its own muscle, which are the muscles of facial expression. And just comparing the eyelids and the lips, they have muscle from the same source. They're all from the same family, effectively. So now we look at overlying the oral cavity, which expands, and the orbital cavity, which doesn't. There are differences in the shutter over. Each of them has a sphincter muscle overlying it. And you can see that the sphincter muscle, as we know, the orbicularis oculi, extends beyond the orbital rim, whereas the orbicularis oris is only within the lips. It would be very difficult structurally for it to continue right up onto the bone. But then that has consequences as well. So reiterating the same basic understanding. So we talked about the difference in the sphincter muscles, and this is the area between orbicularis oris and the ligaments that support the mouth. This is where most aging occurs, around the mouth. And the amplitude of movement is so much greater around the mouth, which is the reason for there's so much more aging there, and why, when you've done a high-quality facial rejuvenation, the area that will relapse in 8 to 10 years is around the mouth, not around the eyes, and that's due to the amplitude of the movement. So here you can see the ligamentous arrangement around the two bony cavities. The red lines, of course, are the ligaments, and the blue are spaces. So there's bony spaces at the front and the soft tissue spaces behind. And you can see that the spaces are adjacent to the bony cavities, and when you think of them, they're glide plane spaces. They're allowing the superficial fascia to move over them, over the roof of the space, and to allow additional movement over the bony cavity. That's their function. So if you look here, this is a section of the cheek that's been detached. We're looking at the underside of the composite superficial flap, where the muscles are very visible, and those coloured beads are the ligaments that have been transected to allow to lift off the superficial fascia. So there's the vertical line of ligaments we're talking about, the zygomatic and mesenteric. Now, if you look more closely, there's traction applied to the main zygomatic ligament there, and you can see that the ligament isn't like a pole that goes straight through into the tissue. It spreads out like the bough of a tree to ramify into the tissue, to embrace it. So there's a good analogy for thinking. So there's the stem attaching to the bone, equivalent to the trunk attaching to the soil, and then there's boughs, and then these boughs turn into branches that ramify into the dermis, which is effectively the leaves. And ligaments are not all exactly like tubular shape, like a cruciate ligament, for example. They are, ligaments by definition are any structure that ties or binds together. So in some areas the ligaments are more like the zygomatic ligaments to find others. There's a diffuse area, the lateral orbital thickening, we call it, and there's even septi, also a form of ligament. So if we look more closely, then a ligament goes from the floor, which is the periosteum, to the dermis, and this shows the tree-like arrangement of a hypothetical ligament. Now, many surgeons say, well, I never release ligaments when I'm doing a facelift. Well, maybe it's not a ligament that he could see, for example, at a trunk, but it's necessary, of course. If you're going to mobilise the skin, then you have to somehow detach it from the resistance of the tree. And so this could be done at one of several levels, subcutaneous, subsmass, or subperiosteal. They all have a place, they all allow movement, but with a different character. Now, what we're going to be talking about more is the subsmass here in this session. But the others are all equally valid with different benefits and limitations. The benefit of the subsmass is it avoids dissection into the composite flap, where there's the delicate vasculature and nerve supply. And also you have for the redraping, the suture can pass into the underside of those branches, the boughs, and grasp that, and so indirectly pulls on the whole flap, not just pinpoint fixation. When you think of, we're talking about the origin of spaces, here you can see adjacent ligaments overlapping like a hedge. But we know there has to be muscle in layer 3, and it's no use having a muscle if it can't work. If it can't contract, it will undergo atrophy. So that means there can't be ligaments underneath, and then there also has to be mobility over there, to allow the shortening of the muscle. So you see the quality of the retinacular cutis is different over the space, over the muscle, compared to over a ligament. So this is the origin of spaces, because that's an adaptation to allow movement. And then in some areas, it's almost like a module of a series of spaces, and each module is constructed around the space proper, with muscle in the roof. You can see the standard format, space, muscle in the roof of the space, retinacular cutis of a different quality over the ligaments compared to over the space. And it's a bit like you go to IKEA and buy a module, and you can click them together. Because what happens, they click together at the interval between the spaces. And the interval is where the nerves and vessels and lymphatics pass up into the superficial fascia. So there's the nerve passing in a predictable place outside the space, but close to the wall of the space. It's just like in the wall over here. There's electrical cables in the wall, and they're very dangerous. But if we stay inside the space, we know we're safe. We're in the room and not inside the wall itself. It's safe. So this is a building analogy. So let's look at the aging changes now of the spaces. It's obvious when we talk about the quality of the retinacular cutis and the repeated movement, shortening and lengthening here, that this is where the wear and tear occurs, not on the fixed point. And so the roof of the space tends to distend. And this is a little law that I've come up with, that the quality of attachment within an area of subcutaneous depends on what's beneath. So if you're operating over a space, it's less tightly attached. If you're operating over a ligament, then it's more tightly attached. And really, this is how David Furness first came across ligaments and described that in 1989, because he was operating with high-power loops directly on the outer surface of layer 3 here. So he could see areas of adherence and areas of less adherence, and hence he alerted us to this anatomy. So we're going to come back to this in a moment about the application of that to explain some anatomical things. So you can see from the surface anatomy point of view, where there's a groove is where the ligament is, where there's a bulge is where there's less support. And this, there we go. Now we're talking about another clinical correlation. Here is deep subcutaneous dissection. And you remember, as the branches of the trees go out, they multiply to multiple smaller ones. So if you do a deep subcutaneous dissection on the outer surface of a muscle, there's not strong adherence there. It doesn't really impact when you're doing a superficial subcutaneous, which tends to bleed more because there's multiple finer vessels there. And this was Owsley years ago described operating on the outer surface of the orbicularis oculi, and it dissects relatively easily. And when you dissect a premasseter space, you might end up in the wrong plane as well. So we'll come back to that. So here's deep subcutaneous dissection. Release is easier there than superficial. So now we talked about the effect of laxity over the spaces. I think you've got the basic understanding. So that the grooves overlie the ligamentous attachments and the bulges overlie spaces. The blue correlate. The jail is the laxity over the premasseter space. And this was written by Sam Hammer when he reviewed our article in 2002. How much clearer could it be? So it's sort of just accepted, it's obvious now. So you could give the analogy, the ligaments are a bit like a Chesterfield couch with the buttons at the point of fixation, and in between the buttons, there is not fixation directly, but indirectly from what's surrounding it. And really the human face is a bit like that. It has areas of fixation with areas of less fixation, alternating ligaments and spaces. So now we look at this three-dimensionally. So you can see the spaces, everything we talked about, but three-dimensionally. Now, when there's laxity in the roof of the space, it's the same. And then this is the safe area here where the ligaments are running, but also the nerves. So that's an area that has to be considered. But if we want to correct laxity in the roof of the space, there are many ways of doing it, operating from superficial down at different levels as we showed. But if you're going to go operating subsmass, then the ligament here needs to be released if we're going to tighten over here. So that's the only reason for releasing a perfectly normal, good ligament is if the surgeon wants to tighten over here and remote to that. So it has to be released carefully. Then the suture is placed in and it's advanced laterally, and also, of course, it comes down to be fixed to the underlying deep fascia. So this is a patient lying on the table, getting ready for a facelift, and you can see the surface anatomy, the indentation, which now all of you can see, and you know there has to be a ligament there, and we're just under the zygoma at the junction of the arch and body. That's the restraining effect of the zygomatic ligament, compared to the mobility surrounding, which is the area of the space up there. So whenever you see laxity, you has to be a space underneath and ligaments nearby, explaining malar mounds, explaining jowls, nails, labial folds, etc. And also explaining this new wave of enthusiasm for subcutaneous compartments, which are really just a surface manifestation of what's going on deeper in. Now, when we look here, this is ultrasound of movement of zygomaticus major. So think about what's happening overlying the muscle. So here's an artist's illustration. You see the subcutaneous layer is very mobile. It cannot be rigid, and therefore it's prone to aging. This very profound area of the nasolabial fold. And you could say the fat compartments are in there, but it's a reflection of the enormous, we talk about the amount of blinking that occurs. We don't really talk so much about the amount of movement of the mouth and zygomaticus major. Now, we were comparing again the similarities and contrasts between around the eye and around the mouth, and we know a bit about the lateral canthal support. It's a very fixed, strong structure. So the lateral canthal tendon goes inside the orbital rim, the lateral orbital thickening, or the superficial lateral canthal tendon, or lateral canthal ligament, it's even been called. But this is the fusion from the underside of the orbicularis down to the periosteum. So there's very strong lateral support on the lateral orbital rim as well as medial. But there's no such support for the oral cavity, which always amazed me. How could this structure stay up there? So if we have a look now, this animation by Mark Sagar, Academy Award-winning illustrator, you can see that movement. There, the zygomatic ligament, and then the mandibular ligament, they're both positioned, by definition, as you would expect, in areas where there's not muscle movement. They're areas in between muscle movements. And these are the two strongest ligaments on the face. Now, we talked about, just changing topics for a little bit, we talked about the change of the form of the skeleton and the retrusion of the anterior face, the muzzle and the nose and the dental arches. And this has major impact on the mid-cheek. There's a crowding of the mid-cheek where the structures of the oral cavity and the orbital cavity are fighting against each other to secure landing space for their ligaments and muscles. And the consequence of this is a very complicated arrangement of the anatomy, where it's illustrated here in blue, the orbital structures like orbicularis oculi, and in yellow is the structures to do with the oral cavity. So you can see there's a horizontal, there's an oblique overlap here where the orbicularis oculi comes down in front of the cheek, and the origin of zygomaticus major and the zygomatic ligaments comes up deep to those. And you can see on this side over here, the blue is the orbicularis retaining ligament above, and the yellow is the zygomatic ligaments below. So that helps explain the difficulty in mid-cheek surgery, which we have to address because it's so important. So let's move on to the facial nerve. We talked about the structures crossing the space, and now we'll talk about the ligaments, spaces, the facial nerve. Well, Charles Bell illustrated this 200 years ago. So what on earth are we talking about now after 200 years? And no one's replicated this detail. What we're talking about is the fact that it's not surgical anatomy. It doesn't relate to the different planes and levels where we're operating. So this doesn't really help an operating surgeon. It's like a map, but the map is not the territory when you're actually there. We need to know exactly how they pass through different levels. So we talked about the second branchial arch, the muscles moving onto the face, where they move to. The facial nerve branches is like the vapor trail behind an aeroplane, tells you where the plane has come from, and the nerves tell us where the muscles have come from, of course. So we can see that, interestingly, that the second branchial arch muscle passes forward of the first branchial arch muscle. So somehow it has to get around, and it passes superficial because it's going to the superficial muscle. So that's why the facial nerve sits on top of the muscles of mastication to get to its final destination. So we have a general plan, we understand the rules where the nerve comes from the brain, and the brain is deep to the deep fascia for sure, comes through the parotid gland, which protects it on the lateral face, and then it's more exposed on the mobile anterior face. So this is the section of the right side of the face. All of the ligaments have been taken down. Zygomaticus major up here has been transected, and you can see the nerves running across the muscles of mastication, across the masseter. You can also see the parotid duct, which is the yellow structure here, very close to the upper buccal branch. But they're going from the deep fascia on this side of the screen to the mobile superficial fascia here. That's the general plan, and now we just have to tie it in with the ligaments to protect the nerve. So we already followed the rules there. I'm sorry, that's repetitious. So the nerves run around spaces. And fortunately, this illustration actually is not quite correct because it's deep to zygomaticus major and minor, and there's only branch there is the orbicularis branch to the side. The predictable locations we talked about. And here there's an exaggeration of the nerve. So we're showing the nerves going flat, then stepping up, and then going across flat on the underside. And you can see it all relates to the line of ligaments here. So this is very important for our surgeons to know where we're operating relative to the nerves. The nerves are deep here, close to where we're operating here, and then on the underside of the muscle there. And this is a very old dissection. I didn't appreciate at the time the significance of all this anatomy. But the beads are the yellow zygomatic ligaments, red masseteric ligaments, and the ligaments have to be released to allow the superficial fascia to be elevated from here, similar to a facelift. And close up, you can see the nerves are under the protection there, and you can see the nerves coming forward. The nerves don't just come vertical, they come obliquely forward, and they look different. So when you're operating, inexperienced surgeons say, how can you distinguish between a ligament and a nerve? Sometimes it's not easy, but in general, there's two things. One is the ligaments are more whiter fibrous. Nerves have little vessels on them, have a little bit of roundness to them, a little bit of fat on them, and they tend not to be going vertical, but oblique. Now let's look at this. This is a very dramatic way of showing what I've talked about. If you think of the face, we're distinguishing from the lateral face and the anterior face. If we could just lift the anterior face up a little bit, put some handles on there, and lift those where those ligaments are still holding the anterior face in place, and you can see what happens to the nerve. The lateral part of the nerve doesn't change, but the vertical part does. It comes up here, like so. So both the lips and the lids, the innervation, as we said, are similar, and it goes through the same tortuous path, if you like to think of it that way, in relationship to the ligaments. Now let's move down the face now, applying this more, and we're looking at a jowl. When I was training, nobody knew what a jowl is. I looked up the literature, there was almost no references, articles with the word jowl, interestingly. We just didn't know. But the jowl is the lower premasseter space. And there it is. Now, what was interesting challenge is where is the the mandibular ligament? Because it looks very far forward where the white circle is. And knowing the anatomy of the anterior border of the masseter runs down and back, and all the articles in the textbook show the masseter with the anterior border is straight running down, and I couldn't see how the ligament could be so far forward from where I thought the masseter was here. And the answer is, the books all had it wrong also on this, even Gray's Anatomy. So the point is that the anterior border of masseter is curved around the oral cavity, curved around the lips, reflecting what's going on more anteriorly. So there is only one mandibular ligament, and it is far forward. It also has impact or implications for the premasseter space because it has this prolongation, the jowl extension, and that's why you see the jowl is going right up and maximal where the mandibular ligament is. So here you can see a beautiful illustration of the lower premasseter space in the middle and the ligaments, and these spaces, they're not on the anterior face, which is where we talked about full movement. They're at the anterior part of the side of the face, but they allow more movement to occur. You can imagine if all the tissues were rigidly fixed to the masseter and the jaw open to be like a tearing effect. So this allows movement to occur. We know there's only two ligaments there, both the front and the back, near the angle of the mandible, and the ligament, a strong fixation of the mandibular ligament, and in between there are no ligaments, and that's why operating higher up on the cheek here with a max lift or a mastectomy, more superficial operations, you still get a benefit down here because there aren't any ligaments resisting the redraping of the superficial fascia in this area here. So you don't need to dissect in there around the mandibular branches of the facial nerve. So here are the boundaries between the front and the back of the space, but here you can see inside of space. And I'm just showing this here for people who haven't done dissection like this. It will be strange for them to see. There's no bleeding whatsoever, and you can see here the underside of the platysma, which varies enormously in its expression. Some people you don't really see muscle fibers, other people it's quite strong muscle. You can see through the opaque or translucent floor, the masseter fascia, and on a thin person you can see the nerves, the lower buccal trunk running across, and a communicating branch. But it doesn't matter, as long as it's covered. So here you see, when you're entering into the lower premasseter space, there's no doorway into here to tell you how to get in, so you have to estimate where to go. Then you dissect forward of the parotid, as far close to the parotid as you can, and then with the green arrow, you're in the space. Back here, you've gone into the parotid itself. You have to recognise that and then go forward. And here, if you keep following what looks like a superficial, easy dissection on muscle, you could find you've been dissecting on the surface of the platysma and not under the platysma, Mendelson's law. Now, clarifying the difference between the buccal fat and the jowl, here you can see the buccal fat is situated in relationship to the masseter and zygomaticus major. Remember that the buccal fat continues up into the temple with various prolongations and has a prolongation. The masseteric extension goes into the middle premasseter space. And here are the main ligaments here in red. And then there's a picket fence arrangement of more hedge-like ligament under the platysma. The platysma doesn't go all the way up. It only goes to the lower key ligament, the middle space. Now, with aging, changes occur because of the massive amount of movement that occurs over time with eating, and you see this laxity develop, so the platysma is no longer as closely applied to the masseter as it used to be. So the space tends to enlarge, and very clearly enlarging here where the jowl is. And also the general loss of tightness of the tissue means that the buccal fat pad is no longer as constrained by its multiple fine ligamentous attachments to the peripheral structure. So it enlarges, and this forms a labiomandibular fold, this forms a jowl, but one can be almost vertically on top of the other, even though anatomically they started out different from each other. Let's move now to the mid-cheek, the surface anatomy of the mid-cheek. We showed that young woman who didn't have any expression on her face, remember, and her mid-cheek was completely smooth, like the rest of her face. And this is from the J. Paul Getty Museum, and this is Alexander the Great. And you see I think he died in his late 20s or early 30s, so this was real, youthful shape. No grooves, just what you wanted to do when you're doing fat injections in this area. And this is the old man in the sculpture next to Alexander the Great, showing the changes with aging. No longer is it a uniform, rounded, full contour. It's now segmented into three bulges, and these are the three bulges with the grooves in between, pulpebral malar, nasojugal, and mid-cheek furrow, having this Y-shape arrangement. This is the mid-cheek. And you can see on this person here, the mid-cheek furrow, nasolabials, number 3 area, malar mound number 2, and the lid cheek area, number 1. Very profound aging changes. We talked about, I showed you a little bit about aging of the mid-cheek skeleton. Here's a bit more background to it, based on axial CT scans, measuring the change. I know this is accurate because I was part of the study for this. So the mid-cheek change, and I'm sure I'll be questioned about this because I'm pretty emphatic about it, is secondary to the aging of the skeleton. And we saw this again. Look at the maxillary tuberosity and think of the support of the soft tissues and the consequences. So here is a surgical application, someone only 25 with a prominent bulging lower lid fat. There are many ways of treating this, but I saw the fact that she has an underdeveloped skeleton and corrected the skeleton with building up the bone here with hydroxyapatite. But there was a little bit of transconjunctival fat removal as well. That's a long-term solution. Again, same solution, correcting the aging of the skeleton. Look at this person, premature aging. You can see the deficiency of the skeleton there. You couldn't get a evasive result like this simply by tightening the soft tissues. You need to correct the volume. So each of those mid-cheek segments has a space in relationship to it. So the lid cheek segment, number 1, is the lid cheek, the preseptal space of the lower lid, prezygomatic space, number 2, and the oral cavity is a space, massive space, over the maxilla that allows the nasolabial fold. So when you look in profile view of the components of the mid-cheek, it's such an interesting condensed area of anatomy because the lower lid is directly above the cheek. So much of the cheek is really the cover over the vestibule of the oral cavity. So there's the prezygomatic space laterally, premaxillary space medially, and then there are ligaments going through, fixing at the upper and lower part of the zygoma, like so. All of those factors contributing to aging changes. And just reminding us why all this occurs is because the muscle of the orbit extends over the orbital rim. It has an orbicularis retaining ligament holding it in place, but it has to have movement. So this is one area where there's muscle and ligament at the same time, which is very interesting. And just moving into the prezygomatic space, coming up towards the end now. The prezygomatic space is not on the lateral face, it's on the anterior face in the area between the orbital and the oral cavity to allow movement, of course. So there's a space there. There's orbicularis in the roof of the space. There's the deep fat, is pre-periosteal fat. This is the SUF fat, the thinner layer of fat through which lymphatics and nerves run to support orbicularis. There's the preseptal space of the lower lid under orbicularis and extending on the outside of the orbital rim. So the prezygomatic space extends over the lateral orbital rim up to the lateral orbital thickening here. And there are ligaments on either side of zygomaticus major, of course. And zygomaticus major is, as we talked about earlier, it's one of those structures of the oral cavity that takes origin high up here, closer to the orbital rim, but lateral to the orbital rim. So when operating here, the zygomatic ligament effect coming down past here, this is the ligament support. It's the oral cavity equivalent of the lateral canthal tendon here. But it doesn't look the same because it has to breach quite a distance, and the ligament itself doesn't go all the way down the same as you'd expect. Now, just a little bit on the lymphatics, which is very new anatomy from Mark Ashton and his group in Melbourne, presented at the ASAPS meeting earlier in the year, showing how the lymphatics come through the lower port of the tarsal plate and go into the orbicularis and through the orbicularis to subcutaneous. And also there's a branch that goes through the orbicularis retaining ligament. So you can see why surgeons who are aggressive with lateral canthal tendon support doing dissection and suturing around here have a high incidence of chemosis because they're breaching the invisible lymphatics in these areas. So just showing application of the principles into facial rejuvenation. There's a clinical aspect to all of this, and that is when you correct aging of the face, these days we know simply moving the soft tissues isn't enough. We need to correct the volume of the skeleton and the soft tissues of under the skin and improve the quality of the skin as well. So that's leading on to next time.